Welcome to your lecture, or your next lecture regarding Part 4 of your books, Drugs Affecting the Cardiovascular and Renal Systems. We've already covered drugs for the treatment of hypertension, so we're going to move on to the next kind of hot topic in the book, which is antilipidemic drugs, or drugs for high cholesterol. Cholesterol is one of those diseases which typically increases the risk for a lot of things, but it's a disease that patients don't really feel. So we call it an asymptomatic disease, kind of like hypertension is until a catastrophic event occurs. Same thing goes for your lipid disorders. Objectives is just explain the pathophysiology, including causes and risk factors, discuss the different types of lipoproteins and their role in cardiovascular diseases, list overall drug classes and specific drugs that are used to treat the disease, compare the various drugs to treat it in regard to indications, mechanism of action, adverse effects, and so on and so forth, and then develop a nursing care plan that includes all phases of the nursing process. So just to get started, you've probably heard a lot about lipids, but do you know exactly what they are? And some of you probably do, and some may or may not know what they are. There's three types which we're going to focus on, and they're not all bad. In fact, you need a small amount of all these types of lipids in order to sustain body function. The first one are the triglycerides, and these make up 90% of total lipids within the body. Their main function within the body is to provide fuel for energy. So without triglycerides, you're not going to have the fuel needed for cellular energy. The next one are the phospholipids, and these are the ones which are essential to building plasma membranes. Around each cell, there's a biphosphid membrane, and that's created by these phospholipids. These components of lipids are found in egg yolks and soybeans, and this is why, if you stay up to date on this stuff, some people say eggs are really bad for cholesterol, and this is the type of cholesterol found in eggs, which you actually need a little bit of. So there are newer studies coming out that are saying no, egg yolks are okay to eat in moderation. Beyond just being okay, they're actually encouraged to eat even if you do have high cholesterol. And that's because they contain so many phospholipids, which we certainly do need. The third one are the steroids, and these are the lipids which typically cause the problems. And the problem that these causes arteriosclerosis, which are where little plaque formations build on the walls of the arterioles. And when those plaque formations build, if they're small, it doesn't cause a huge problem, but as they get larger, they can occlude blood flow, or they can break free from the wall of the arteriole and start traveling around the body and then occlude blood flow elsewhere, which when blood flow gets occluded, cellular tissue dies, so then you have your CVAs, MIs, pulmonary embolisms, catastrophic events such as that. The main cholesterol, or the main steroid that you think of when you think of the steroids for lipids is cholesterol. And cholesterol is the building block for a number of essential biochemical functions in the body. And this includes vitamin D, bile acids, which are needed for digestion, cortisol, which we've covered in chapter 33 about what that does as far as stress goes. It's your stress hormone. Cholesterol is also needed for the formation of estrogen and testosterone. So you do need a little bit of cholesterol in your body. If you were to completely cut it out, it would cause problems. The dilemma Americans face is that it's really, really easy to get cholesterol in your diet, and we tend to overdo it. 75% of your cholesterol comes from other chemical processes within the body, so your body does generate a little bit of cholesterol, quite a bit of cholesterol on its own. But then the other 25 needs to come from an exogenous source or an outside source, which would be your diet. The American Heart Association recommends less than 300 milligrams per day. And I challenge you to pick up any item in your kitchen, especially if it has to do with soup, frozen pizza, ramen noodles, probably a lot of stuff you have being in college, and just take a peek at the cholesterol and you'll see that it's fairly high. In addition to that, meat also tends to have a lot of cholesterol, but you need the protein because you need it for your body function. Just be kind of aware that it's really, really easy to meet that 300 milligrams per day, and it's also really easy to overshoot it as well. So the lipoproteins, this is simply a term that consists of cholesterol, triglycerides, and phospholipids. So it's kind of a umbrella term for your different types of lipids. They're formed to allow lipid molecules to be transported through the water-based bloodstream. So you need lipoproteins in order to move not only lipid molecules, but also your medications, which are lipid soluble. There's three we worry about. The HDL are the high density lipoproteins. And I think the high, and remember I want a high level of these. Your HDLs are your good cholesterol, and they're the ones that go up and they pick up the bad stuff, deliver it back to the liver, and then it gets metabolized and sent to the kidneys for excretion. So you want a high level of your high density lipoproteins. Now on the flip side, you have low density lipoproteins, and your LDLs are your bad cholesterol, and too much is what's going to help clog the arterioles or result in an arteriosclerotic plaque. In addition to the low density lipoproteins, we also have the very low density lipoproteins, which you can think of as the very bad cholesterol. Both the LDLs and the VLDLs are going to contribute to plaque formation. So you want low levels of those and a high level of your high density. Your LDLs and VLDLs are what you're going to find in like fats, like bacon would be really high in that kind of stuff. Your HDL tends to be found in fiber. So like if you need to increase the high density, you'd encourage your patient to eat whole grains, apples, fruits and vegetables, whole grains, stuff of that nature. A few more terms for you to know, and these get pretty technical. Most of the time we just say somebody has high cholesterol, but if you want to start delineating out to what type of high cholesterol they have, we can do that as well. Hyperlipidemia is simply referring to high amounts of lipids in the blood. Now, this is a major risk factor for cardiovascular disease because the type of high levels that most people have, it doesn't tell you exactly what type, but it's kind of assumed that's probably a high level of LDL and VDL and not a high level of HDL. Now, every once in a while, you will have patients come through with a high level of HDL and the other values are normal, but when you look at the printout, it spits out, say, oh, they have high lipids. Well, if the high lipid they have is the HDL, then we're actually not concerned at all. We're quite happy about that. And then you have hypercholesterolemia, which is simply an elevated blood cholesterol, and that's never good. We don't ever want just the cholesterol to be high. And then dyslipidemia is simply referring to abnormal levels of lipoproteins. Again, this could be good if the abnormal levels, you have an abnormal high HDL level and an abnormally low LDL level. So not necessarily bad, but most of the time it's referring to a high LDL level and a low HDL level. So controlling lipids, because when somebody gets diagnosed with high lipids, the first thing we recommend is lifestyle changes. If we can control this disease with lifestyle changes, that is the most beneficial. So what we'll do is we'll tell patients to maintain weight at an optimal level, find your appropriate BMI, and then keep your weight there. The less amount of adipose tissue a patient has, the better off they are at controlling their lipids. Now, that's not to say that every overweight person has high lipids, and it's also not to say that every normal or appropriately weighted person has normal levels. I know many people who they look physically fit, and they still have a high lipid level. And that typically comes from the third point there, their diet. But not always. It can also be genetic. Other factors which increase or that we encourage to modify, including exercising more, and the type of exercise we like is the exercise which is going to get the heart rate up and keep it up. So brisk walking, jogging, dancing, rollerblading, stuff of that nature. And then with the diet's going to be the big area that we can really make an impact on these patients. We want them to reduce their saturated fats and their cholesterol, but then we also want them to increase their fiber. By doing those two things, it's going to make the biggest impact on their lipid level. If they're a smoker, we encourage them to stop. But when lifestyle changes alone are not enough to treat your high cholesterol, you can ask your doctor about starting a medication. Or rather, typically your doctor will tell you to start a medication. And of course, the medications are where we're spending the most time today. And there's not a whole lot out here because the ones that we have are fairly good at what they do. There isn't a huge drive to produce new ones. So this is going to be relatively straightforward. The first group we're going to talk about are the HMG-CoA reductase inhibitors, and that's a very fancy term for a statin medication. I would wager to say most of you, if you've watched TV in the last 10 years, have heard a commercial for a statin medication, especially if you watch TV during prime time when a lot of older people are watching TV too. These are going to be Crestor type drugs, simvastatin, which is Zocor. I think the current commercial is they've got a team of bowlers and they all have the orange jerseys on, and it's like, go Lipitor, and I don't know. If you see it, now that I've said it, hopefully you see it so I don't sound silly, but they're advertised a lot. Moving on, how these work is they decrease the rate of cholesterol production, and they do so by inhibiting the HMG-CoA reductase inhibitor, or enzyme, which results in less cholesterol biosynthesis, so less cholesterol is being synthesized by the liver to be turned loose into the bloodstream. As the liver makes less cholesterol, the body responds by making more LDL receptors on the surface of the liver, which is really, really good because the more LDL receptors the liver has, the more chances the liver has to grab that low-density lipoprotein, pull it in, and then get rid of it. So we like to have a lot of receptors for the LDL. By grabbing the LDL fatty protein things from the bloodstream, it helps reduce the circulating amount of LDLs. And when you check a cholesterol, so you go to the doctor and you get your blood checked and they tell you your cholesterol level, it's testing the amount of cholesterol floating around the body. So if the liver is grabbing it and excreting it, it's a good thing. These medications, some of them are prodrugs and some of them are not. The drugs which are prodrugs from this category are going to be lovastatin and simvastatin. The only thing you really need to remember about this are with prodrugs, the liver needs to metabolize them in order for them to be valid. So if a patient has liver disease, this would not be the medication that they would go on. The indications, technically it's for hypercholesterolemia or for low HDL levels, which if you can remember that it's for high cholesterol, that's going to be perfectly acceptable for this class. Contraindications for this medication include if they're pregnant, and this is going to become, you're probably thinking, well, most people with high cholesterol probably aren't trying to get pregnant, but there is a significant portion of the American population that has genetically high cholesterol, and those would be the people who might be younger and on a statin medication. So what you want to think about is if you happen to be working in a women's health clinic and you have somebody coming to you and they're trying to get pregnant and they're on a statin medication, you might need to advise them that it's time to get off that, or just bring it forward to the doctor that this patient who routinely comes for a gynecologic checkup just mentioned to me she's ready to get pregnant and I see she's on this medication, just kind of advocating for the patient that this might not be a good idea. Not that they can't get pregnant, they just need to get on a different medication while they're pregnant. The other contraindication is going to be liver disease because these medications can induce liver failure. Some of the adverse effects, most of them are pretty mild and well tolerated. Maybe some nausea, headache, rash, but nothing real significant. The more significant ones, though, are going to be the myopathy, which is muscle pain, and that muscle pain can progress to rhabdomyolysis, which is a lot more serious, and we'll talk about that a little bit more on our next slide. The third major side effect is going to be liver failure. And for the liver failure, if you want to skip down for me for just a few seconds, you want to monitor liver function every 3 to 6 months for the duration of this medication's life. So if somebody's on this medication for 20 years, about every 6 months they're going to go get their liver enzymes tested just to make sure that their liver's not getting damaged from the medication. They'll get checked closer to the 3-month mark if their liver's starting to do funny things, or if they have other comorbidities, say they have hepatitis or something and they're more concerned. If they're not concerned, they just want to keep their eye on it, then they'll push out to that every 6 months. Okay, Jumping back up onto the rhabdomyolysis, because some of you guys may know what it is and some of you guys may not. This is a disease that's characterized by rapid muscle breakdown. And with that rapid muscle breakdown, you'll see what we call myoglobinuria, which is simply a high level of muscle byproduct within the urine. This is a clinical manifestation of the disease. The patient probably won't feel it, but when you look at the urine, it's going to look really concentrated, and it'll have kind of a goofy color associated with it. And then we'll test and we'll get a value back that confirms that diagnosis. What we get concerned about with rhabdomyolysis is that it's going to cause acute renal failure because the kidneys are not made to handle that much of a muscle breakdown. So it's the acute renal failure which can be deadly, in addition to the muscle wasting, which if it went on long enough would also be deadly. So it's a really big deal that we watch patients for the onset of rhabdomyolysis after starting or increasing their dose of a statin medication. Some of the risk factors here include starting or increasing the dose of a statin medication. Sadly, it's not unusual for a patient to be on simvastatin and they've been on it for 5 years and now they just need to increase the dose. Even though they've been on the medication, just that increase in dose can sometimes induce this side effect to occur. So we always watch patients when they're first started and then anytime the dose is increased. And as a nurse, you just pass that information on to the patient. Now that we've increased your dose, make sure you report any muscle pain right away. The next side effect or risk factor is going to be patients who are older than the age of 65 or more prone to it, patients who have been diagnosed with hypothyroidism or renal insufficiency, and then patients who are also using this medication called gemfibrozole or Loped, and we'll cover that in a few minutes as well. It's another cholesterol medication. The treatment for rhabdomyolysis, the first thing is they need to stop the medication. So the medication will either be stopped or it'll just be held until this condition resolves, and then they may opt to try the medication again, or they may opt for a totally different medication. That kind of falls to the physician to weigh the pros and cons and decide which route to go. But the first thing we do is if a patient calls and they say, hey, I got started on simvastatin, my muscles really ache, what should I do? You're going to say stop the medication and come in right away. And then they'll get evaluated, and if they're sore because they raked their yard, then they'll say, oh, yep, go ahead and restart your medication, you're okay. If they're having muscle pain because of this condition, and they'll do tests to confirm it, then we say stop it, just stay off it for a while. If it gets to the point where it's significant enough to be administered into the hospital, we'll start IV fluids, and then we'll actually dialyze the patient. So we'll send them to dialysis a couple times to help clean out the blood and relieve the pressure on the kidneys as well. So it's kind of a significant thing there for them to go through. And I know a lot of these side effects seem like they never ever happen, but about once a year we get a patient admitted to the hospital on the unit I work on that's been admitted for rhabdomyolysis because of their statin medication. So it happens probably more frequently than you would think. Some of the nursing considerations for this medication is we typically give, as a general rule of thumb, give this medication in the evening. The reason why we give it in the evening is it allows the concentration of the medication to be at the highest point when the patient is sleeping. Your liver does its best job of synthesizing cholesterol when you're not eating. So that's why we say take it when you go to bed. That way the medication can do its magic when hopefully you're not eating. And then when you wake up and you start eating breakfast, every time you eat, it interrupts the liver's ability to synthesize cholesterol. So by the time you start interrupting the liver's cholesterol synthesis, the medication's already done most of its good, and then you get a little bit of a drug holiday, and then you take it again that night. So it's essentially just working at the same time as your liver's working. Typically, the benefit of this medication is increased when it's combined with another agent, so we'll talk about a couple other agents which can be used, and when lifestyle changes are also made. So this drug works best when they also alter their diet to decrease their saturated fats and increase their fiber, and they start exercising and maintaining their weight. Keep in mind, all of the statin medications are category X, so they're not appropriate for people who are attempting to get pregnant. And kind of think about your younger women who are genetically predisposed predisposed to high cholesterol levels. And I can think of two people that are my age, so they're in their 20s and they have high cholesterol, and they're both very fit people. They both work out. The one just ran a marathon, but they just genetically have the high cholesterol. So it does happen. It's not a huge portion of the population, but enough to be kind of aware of it. And then also you're going to monitor and educate. You're going to be monitoring the onset of muscle pain and telling your patient as soon as you feel any muscle pain, you need to call the clinic right away. And you're going to tell them that this can happen not only if this is a new medication, but also if we've increased the dose at all. And then monitoring liver enzymes. Again, about every 6 months, they're going to come get that checked just to make sure their liver's not being distressed at all. These drugs are super easy to identify. You've been hearing me call them a statin medication because that's easier to say and remember than the HMG-CoA reductase inhibitor. But these are easy to identify because they all end in S-T-A-T-I-N, or T-I-N, statin. So you have atorvastatin, simvastatin, lovastatin. There's about 7 on the market. It doesn't matter what first letters I put in there. If it ends in statin, all it does is lower cholesterol. That's what it's good at. So the two that your book identifies are atorvastatin, which is also known as Lipitor, and this lowers the bad cholesterol while increasing the good. And it's a very, very common medication for patients to go on when they go on a statin medication. It's a little bit newer, and the big benefit to atorvastatin is it has this really long half-life. Now, the rule of thumb for statin medications is we give them at night so that they can do their most good while the patient's sleeping. This is the one that kind of goes against that rule, in the fact that because it has a longer half-life than the rest of them, it can be given at any time during the day, and that half-life is going to carry the patient for the duration of the day. So this is a drug that if they want to take in the morning with the rest of their medications, it's fine. It will still do its thing. Now, when we talk about like simvastatin, that's not what goes. Simvastatin really should be given at night for maximum effectiveness. The other thing I want to point out, the difference between these two drugs is you can see what a high dose the atorvastatin needs. The range is it is double of that of what Zocor is. So it's not quite as potent of a medication either, so they need a higher dose of it. It's probably irrelevant. I'm just kind of pointing it out to show a couple of the differences between the two drugs. Zocor is also known for a lot of its interactions, and I'm not going to make you memorize them, but just know simvastatin doesn't share the sandbox real well with any other medication. It kind of likes to be all by itself, which is another reason why it's not used quite as frequently anymore. But you certainly will still see it in practice from time to time. The next group of medications to cover are the bile acid sequestriants. These are going to be second line to the statin medications, but they do still have a place within our healthcare system. If you look at the indications, they can be a primary therapy if the patient doesn't tolerate a statin drug. Say they keep getting rhabdomyolysis and it's not working for them. This would be the fallback therapy to that. They also may be used as an adjunct therapy to the statin medications for patients whose cholesterol is really poorly controlled. So they certainly do have a place within our system here. How they work is they bind to bile to prevent the reabsorption of bile acids from the small intestine. So essentially this medication stays within the GI system and does all its work without ever getting absorbed. The fact that it can do its work without getting absorbed limits its side effects significantly. And that's a huge benefit to that. Now, by preventing the reabsorption of bile acids are necessary for the absorption of cholesterol. And what happens when you eat is it stimulates your gallbladder to release bile acids into your stomach, and those bile acids go and they start binding to cholesterol, and then they get reabsorbed. So then they go from your gallbladder to your stomach or to your small intestine back to the bloodstream. What this medication does is when they get stimulated to go from the gallbladder to your small intestine, it binds to them and it prevents them from getting reabsorbed. So it just keeps them in the small intestine and then they get excreted via the stool. So that's how these medications work. The liver does respond to this by converting stored cholesterol into bile. So your liver is kind of like your big storage bin. It stores glucose and stores cholesterol. When it's noticing that it's running low on its bile acid from the gallbladder, it triggers the cholesterol to go to its little storage unit and start pulling out cholesterol, and then it turns that cholesterol into bile. So don't think you're going to become deficient on your bile acid. You're not. Your liver is like the hoarder of your body, and it's got plenty to go around. So your liver will just get more bile, which is okay. You need bile in order to function, but that is one of the things that happens with this drug. When the liver does this response, so when it converts its stored cholesterol into bile, this also increases the number of LDL receptors, which, similar to the statin medications, this reduces the amount of LDLs floating in the system. So it's certainly not a bad thing. And again, it's a primary therapy for those who can't tolerate a statin medication. So even if it's not that they can't tolerate it, but say it's a young woman who's trying to get pregnant and she's got high cholesterol, they may switch her from Lipitor or atorvastatin to a drug from this category while she's pregnant. Then once she's done breastfeeding, they'll go back to their statin medication. Or it might be used as an adjunct therapy with the statin drugs. The side effects, because this is it's limited to the GI system, your side effects are also largely limited to the GI system. In order for a drug to cause systemic side effects, it must be absorbed. So if you can remember that this drug is never ever really absorbed, it just does all its work in the GI system, it should make sense that all our side effects stay within the GI system. The most notable one is going to be constipation. So we will encourage our patients to increase their fluid intake because that helps relieve constipation. And then we also encourage them to increase their fiber intake. In addition to relieving constipation, this is also going to increase their HDL level. So that's a really good thing for those two reasons. It relieves adverse effects, plus it naturally helps increase their high density levels, which of course we want high. It can also cause a little bit of heartburn and nausea, bloating and belching. And those, especially the heartburn, nausea, bloating, and belching, are all going to decrease with time. So they might be really noticeable when they first start the medication, but then over time they're not going to notice them quite as much as the body becomes a little bit more used to this medication. The only drug from this category you're required to know is Questran or cholecystyrene. And just a few particulars about this in addition to what we just covered. This drug does have a high affinity for many other drugs. You don't need to remember which drugs it likes to bind to. Remember, affinity means it likes to bind to those medications. I'm not going to require you to remember that list of drugs. What I want you to take away from knowing that it has a high affinity for other drugs is that it's good to take this separately from other daily medications. So if you take your daily medications at, say, 9 o'clock, it would probably be a good idea to get this into your system at 7 or wait until noon to take it, just so it's not binding to those other medications. The other thing is that because it absorbs to bile, the bile is not absorbing to fat-soluble vitamins then, and therefore those fat-soluble vitamins are not going to be absorbed. Your 4 fat-soluble vitamins are A, D, E, and K, and they're all important, but the one that I want to highlight is vitamin K. Vitamin K is very much so needed for clotting factors, so if you become deficient in vitamin K, it increases your body's ability to form a blood clot. Or excuse me, I said that backwards. If you become deficient in vitamin K, it decreases your body's ability to form a blood clot, and then you become more prone to clotting. So just know vitamin K and clotting, they go hand in hand. And then the other funny thing about this is it can be used off-label for chronic diarrhea. So sometimes you might see it used in that aspect. It's not frequent, but it could be used for that as well. The next drug we have to cover is both a drug and a vitamin, and that's niacin. Niacin is actually a B complex vitamin, and I believe it's B3 if I'm remembering right. But I'm just going to point out that your daily recommendation for vitamin B3, according to the nutritional guidelines, is 25 milligrams per day. In order for niacin to be effective as an anti-cholesterol medication, you need to take 2 to 3 grams, which would be 2,000 to 3,000 milligrams per day. So it's a substantially higher dose needed for cholesterol management than for your daily recommendations. However, because it is a vitamin, it is over the counter, so sometimes patients will get a wild hair to just start this medication because they heard on the Dr. Oz show it's good for them. So just be aware, sometimes they'll start self-prescribing this. Not that's probably going to hurt them a whole lot, it just sometimes they do it and they need to let their doctor know that that's what they're doing. Exact mechanism is truly unknown. We think it inhibits lipolysis in the fatty tissue. We also know it decreases the esterification of triglycerides in the liver, which decreases triglyceride production. And then it also increases the activity of the lipoprotein lipase, which destroys LDL levels. So we know it works in a couple of different, or we think it works in a couple of different ways at contributing to lowering the blood cholesterol level. Now the other thing that we know it does, and this is where the side effects come from, the first one's a cutaneous vasodilation. So it goes to the very superficial arterial system, so the stuff within your skin, and it causes those to vasodilate. As the blood vessels near the surface of the skin dilate, it causes flushing, so patients will get really flushed after taking this medication, and it also causes hot flashes. For that reason, middle-aged women really hate taking this medication, and this is something where, like, they'll hear that this is a good thing to take, so then they start taking it like crazy, and then suddenly they're always flushed and they're always hot and they don't know what's going on, and then they'll come to the doctor. So sometimes we'll see this come out in that aspect as well. The other thing is it induces the release of histamine, and we're going to talk about histamine in the GI system when we talk about GI medications. But one of histamine's roles, in addition to being part of the inflammatory process, is it helps regulate the gastric secretions and gastric motility. So if you kick histamine into overdrive, it increases gastric motility, which can cause diarrhea, and then it also increases gastric acid secretion, which can cause heartburn and nausea. So that's where some of your GI or weird side effects from this come from. The indications, it decreases LDL levels, it decreases triglyceride levels, and niacin also increases HDL levels. Now the interesting thing about this is niacin can start working within 1 to 4 days, which is relatively fast for a cholesterol medication to work. You will note that it takes up to 5 weeks to see the maximum effect for these though, but they're relatively quick acting. Some of your contraindications for niacin include liver disease. In high doses and then also in the extended release tablet, it can cause liver failure. If they're taking an immediate release tablet though, it shouldn't cause the liver disease, but regardless if somebody already has some sort of liver problem going on, we typically just say don't take niacin because there is this risk associated with it. The last contraindication would be peptic ulcer disease, and this is because it's inducing that release of histamine, so that increases gastric secretions, and your gastric secretions are very acidic. If you had acid to an already open peptic sore, it's going to make that sore worse, or if a patient is predisposed to developing ulcers, it's going to trigger the formation of an ulcer. So therefore, patients who have peptic ulcer disease, we don't really want them taking niacin either. Some of your adverse effects, for the most part, they're just uncomfortable, except for hepatotoxicity. But some of your uncomfortable ones that comes from the cutaneous vasodilation, it's going to be the flushing and the hot flashes. For this, menopausal women typically don't want to take this medication, or they'll start it and they'll stop it right away because they're already going through hot flashes, and now this is making it worse. Also, keep in mind, many people get diagnosed with high cholesterol about the time they go through menopause, so it's not unusual to see physicians attempt to put a menopausal woman on niacin, and it doesn't always work out so well. Fortunately, there are things we can do to help decrease the amount of hot flashes from the vasodilation. The first one is to take an NSAID or an aspirin 30 minutes prior to taking this medication. So if they can remember to take their ibuprofen before taking their niacin, it will help decrease some of those uncomfortable side effects. The other thing we can do is, instead of starting them right on their 3 grams a day dose, we can start with maybe 1,000 grams a day and then slowly increase it until we hit the recommended dose. So we can utilize those too, and that'll be important to remember for your exam. And it's important as a nurse to remember, well, how can we make the patient's life better anyway? So if I ever give you a tip on how to make the patient's life better, it might be worth highlighting if I were you. The other things this can cause is nausea, excess gas, and diarrhea. Again, it's working on increasing the GI motility, so it can cause some of those uncomfortable GI side effects as well. The one serious one is hepatotoxicity, and again, it's noted more with the sustained release tablet, not the immediate release. So if they're taking the sustained release, we worry about it more. As a rule of thumb, though, if somebody has liver failure, we just encourage them not to take this medication, or it would be a bad idea for those particular patients to start self-medicating with niacin. The next medication, I've already mentioned it once when I talked about statin medications, and I talked about with statin medications with the rhabdomyolysis, but it's Loped or gemfibrozil, and this is technically a fibric acid derivative, and it's a really, really old medication. It was once the gold standard for lowering cholesterol, but it's largely been replaced by the statin medications. The reason why it's been replaced by the statin medications is they do a slightly better job at lowering the cholesterol, and they happen to be just a little bit safer. The mechanism of action of Loped, though, is it activates the lipoprotein lipase. By doing this, it helps inhibit or it helps increase the breakdown of cholesterol. So if the body is breaking down cholesterol, it's not floating around the body, it's getting excreted, and it lowers cholesterol levels. It also breaks down both the VLDL and LDL, which then allows them to be excreted as well. In addition to activating the lipoprotein lipase, it also suppresses the release of free fatty acids from fatty tissue. It inhibits the synthesis of triglycerides in the liver, and then it increases the secretion of cholesterol into the bile. Now that fourth mechanism of action is the reason why it increases the risk of gallstone formation. And it's really, really good at increasing gallstone formation. So most patients who go on this eventually get their gallbladder removed because it gets blocked up with gallstones, and that's very painful for the patient. So that's another reason why it was kind of replaced by the statin medications. Some of the indications for this, it decreases triglyceride levels by up to 43%. It can reduce the total cholesterol by up to 11%. Specifically, it reduces the LDL cholesterol by 10%, and then as a benefit, it increases the HDL level by 10% as well. So it's really good at lowering what it needs to lower and increasing what's good to increase. The other benefit, and it can be either a benefit or a drawback, is it alters the clotting time. By increasing the prothrombin time, it enhances anticoagulant therapy. So if you have a patient who's prone to clotting, it will help protect those patients. But if you have a patient who's not prone to clotting, it can actually increase their risk of bleeding. So it's kind of a double-edged sword for that indication or for that mechanism there. Some of the contraindications and the adverse effects here of Loped, severe liver or kidney disease, it is a little bit more prone to causing rhabdomyolysis, especially if it's with the statin medication. So we say if they have kidney disease, the risk of rhabdomyolysis is too high. It'll induce acute renal failure, and it'll just fry those kidneys. We also use this cautiously in patients who have liver failure. And then if people are prone to developing gallbladder stones, we also use it cautiously in those as well. Some of your adverse effects, some of them are just obnoxious, like the abdominal discomfort, diarrhea, nausea, and then the increased risk for gallstones. Loped is just so known for that. So kind of have that highlighted as you're writing it down as well, or put a little star next to it that Loped really likes to increase the risk for gallstone formation. The last one's a rhabdomyolysis, and again, I've said we don't really like to combine this with the statin medication because it induces massive muscle breakdown, which is the kidneys try to compensate for that, can induce this rhabdomyolysis, and then they end up in the hospital and they end up on dialysis, and it just ruins their whole day. There's just a couple miscellaneous drugs I also want to cover. The first one's Zetia. Zetia is kind of a neat little medication, and the fact that it acts a lot like the second group we talked about, the bile acid sequentrients, that inhibits cholesterol absorption from the small intestine, and it's actually been proven to decrease the absorption by up to 50%. Unfortunately, with this drug, the body will respond by synthesizing more cholesterol, and instead of also synthesizing LDL receptors, it just lets go of its cholesterol, so eventually it lowers the cholesterol, but then eventually we see the cholesterol rise back up. So it's only good for short-term use. Typically, it's given with the statin. It's very well tolerated, so it might be good for a while. It just isn't a long-term thing. And then the next one is omega-3 acid, and this is also an over-the-counter medication that's really, really good for people to take unless they have an allergy to seafood. It's just known to help decrease cholesterol levels. Lots of people take it. It's also got antioxidant properties, and then it can also act a little bit as an anti-inflammatory. And they're thinking because of that anti-inflammatory, omega-3 can actually also help protect against Alzheimer's disease. So we see it used in a couple different ways, but just something to kind of help you remember. Something you may wish to remember is that omega-3 can also help lower cholesterol. So here's just a quick recap of your medications if you want to pause, and if you're somebody who really likes lists and you just want your list of meds, here's your list of medications from this lecture only to know. And then the other thing I've done on this outline, because a few people said it was helpful when I did it for chapter 3, is I just quickly outlined the nursing process. I'm not going to read it to you, but essentially some of it's from the book and some of it's just stuff I thought of. So as you go through, it can kind of help you identify what you're assessing for when you assess the patient, picking up people who are at a higher risk of developing high cholesterol, and then some of our goals, and I've tried to kind of sprinkle through here how these medications help achieve those goals. But a big thing is to remember that we're going to use these drugs in addition to lifestyle modifications, so diet alteration is huge. And then also, a lot of these medications are either known to increase liver failure or to induce liver failure, gallbladder formation, or renal failure. So kind of know some of the big side effects and know which drugs you need to monitor for and which ones are not as big of a deal. And that concludes this lecture.